Okay, so welcome to the N3C Community Forum for February 27th, 2023. Excellent. So a couple reminders, welcome. The presentation will be recorded and will be archived in the CD2H YouTube channel. And remember, please use the Q&A button on the bottom to post your questions. Also, use the raise the hand feature for the host to unmute your microphone. For anything else, please post in the chat section. Okay, so important, we're reviewing this a couple times, but it's important change coming up. So effective March 13th, 2023, we're going to have forum topics expansion. So again, we're going to expand out from just COVID related to a larger range of topics for real world data analytics. And a new forum meeting pattern effective March 13th, 2023. We are going to go to a bi-weekly schedule, same time, Monday at 5 p.m. Eastern or 2 p.m. Pacific time. And also there will be a new Zoom host, and registered forum attendees will be automatically moved to the new Zoom. Registered attendees will receive an email with a Zoom link. And of course, we always want to hear your thoughts, so share your thoughts, looking for ways to bring relevant and exciting presentations to the forum. So as you can see, we've expanded the topic, so hopefully we get great ideas for that. And there's a forum feedback link. So yeah, just an overview of some of the topics that were upcoming topics, right? So you can see March 6th. We're going to look at real-world data de-identification methods and considerations for ethical AI and data distribution. March 13th is still to be determined. And March 27th is R3 talks, Recover talks, from some of our local people here. And then April 10th, the future and the role of cancer data semantics. Okay, so we get to look at our key figures for this week, and again, you can see that we're continuing to grow. We have 77 sites, 18.1 million persons, 7.1 million COVID positive cases, and total number of rows of 22.7 billion, and clinical observations, 2 billion, lab results, 10.8, 3.6 billion medications, now almost 1 billion procedures, and 1.2 billion visits. So if you go to the dashboard, you can see these data in more detail. Okay, so let's get started for today's talk. And this is so we're going to be hearing from Dr. Andrew Southerland, from UVA, and on the increased stroke severity and mortality in patients with SARS-CoV-2 infection and analysis from the N3C database. So I think Andrew can share a screen now.
Great. Thanks for having me. Let me go ahead and try to share my screen. All right. Hopefully everybody can see here. A thumbs up. You all can see my screen. Well, great. Well, I want to thank the group for having me tonight to talk about this recent publication by our group, an analysis really that's been ongoing for some time related to stroke severity and mortality in patients with concomitant SARS-CoV-2 infection. This is coming out of the neuro domain, which we're happy to help lead here at UVA, but it is a collaborative effort. There are a number of folks, as I'll address on the end, who contributed to this. I just get to be the messenger tonight. So thanks for having me. I'll just go through the slides, but please feel free to unmute and ask questions or raise your hand throughout, or if there are questions in the chat, someone feel free to let me know. But we'll get started. I do have some personal disclosures here, just relevant research support regarding stroke care, so non-remunerative intellectual property that's unrelated to what we're going to be talking about, and then some consultant work in addition to our acknowledgments at the end for the support for for the data analysis. So what is the main issue we had attempted to tackle with this analysis from the neuro domain? Well, there have been a number of publications in the stroke literature, that's my area, my field, where we've seen associations in a variety of different ways between SARS-CoV-2 infection or COVID-19 illness and stroke. And stroke, for those who are not stroke experts out on the call tonight, is really a broad disease. It can encompass a variety of different cerebrovascular outcomes, but primarily we're going to be focusing on the two main categories of stroke, both ischemic strokes, which are caused by a blockage of blood flow to the brain and neurologic damage, and then hemorrhagic stroke, which is caused by bleeding on the brain. And these are our two big categories: ischemic strokes making up roughly 80 to 85% of all the acute stroke patients that we see in the hospital, and hemorrhagic stroke making up the remainder, 15 to 20%, but oftentimes more severe. And so we were interested in both of these types of stroke and their associations with SARS-CoV-2. There have been a number of publications in the literature prior to our work and subsequently since we began our work, but most of these data, particularly the early publications, were limited by relatively small sample size. And we're also confounded by data coming out of the early months of the pandemic. Why is this relevant? Well, like in many of the other diseases, we saw changes in the systems of care for stroke patients early on in the pandemic that were unrelated to the biological association between the two conditions. Primarily, we saw a change in the way that stroke patients were brought to the hospital by EMS and other acute emergency mechanisms that may have affected some of the demographics of stroke that we were seeing. And so we were really interested in looking at these associations, not only from the early months of the pandemic, but all the way through the entire first year of the pandemic. And then again, talking about hemorrhagic stroke, there have been very little data published on that here before this analysis. And we saw the N3C database as a great opportunity to really explore some of these associations and confirm whether or not there really was an association when we look at a large multi-center data set throughout the first year of the pandemic. So that's sort of our marching guideline when we began the analysis. So just a little background before I tell you specifically about our project itself, just leading up to why we think there may be this association between stroke and COVID-19. This is older data from 2007 to 2009 from California Emergency Department database. This is work done by a colleague up at Columbia, Amelie Bahim, whose group does a lot of prior research on associations between infections and inflammatory syndromes and stroke. And this is data on patients with influenza coming into the emergency department. And it showed that not only was there an association with younger patients having stroke with influenza, but it also found a durable association in the early 2 weeks after an influenza infection, just hallmarking kind of this potential relationship between influenza-like illness, which we can draw some parallels with SARS-CoV-2 and stroke, particularly in young patients having stroke that otherwise don't have typical stroke vascular risk factors. And when we look at other coronaviruses and prior syndromes and epidemics, we actually saw reports in the original SARS epidemic that saw an increase in the number of large artery ischemic strokes, critically ill patients we were seeing coming in with large artery ischemic stroke. This is a publication from back in 2004 related to that original, one of the original SARS epidemics. And then if we look further to sort of SARS-CoV-1 and stroke, we also saw this is data out of China, published in 2020 in Journal of Stroke and Cerebrovascular Disease. We saw 5% of critically ill patients also suffered large artery strokes. And so again, suggesting that perhaps there's some association there. And then when we bring it forward to the early days of the COVID-19 pandemic, we saw autopsy reports coming out of China that actually showed some specific relationship between in situ vascular disease and COVID-19 or SARS-CoV-2 infection. And the possible relationship between SARS-CoV-2 infection and vascular disease relates to inflammatory state of the endovascular tissue, the vascular vessel, blood vessel wall, shedding of endothelial cells, and as you'll see in a moment, potentially evidence of thrombus formation or actually clot formation inside the arteries. This is just pathological specimens from that same early report from China, showing these inflammatory cells in the walls of blood vessels This is not in the brain. These are in the kidneys, the bowels, the pulmonary arteries. But again, supporting this hypothesis that there's an intrinsic endotheliitis in these SARS-CoV-2 infected patients. And this is early data out of the ICU, talking more specifically about thrombotic complications that in hospitalized patients with COVID-19 pneumonia, this is a cohort of less than 200 patients, that almost a third had some thrombotic complication. And again, thrombotic complication indicates some deep vein thrombosis or large artery clot that's coming out of these ICU infected COVID-19 patients. And then this was something that really caught the attention of the academic stroke world. This was a publication in New England Journal of Medicine in 2020, April, the first couple of months, once we really were trying to understand the pandemic. And this is a publication, New England Journal of Medicine, a correspondence, a case series of 5 patients, young patients coming in with what we call large artery or large vessel occlusive ischemic stroke. These are people that have blood clots in the large arteries in their brains. They're young stroke patients. They don't have typical vascular risk factors. And so it's a curiosity as to why they would be having strokes of this magnitude at a young age, and concomitant to these case reports having COVID-19. And there was this sort of the suggestion that COVID-19 is increasing the likelihood of having these most severe forms of ischemic stroke. And again, striking that this was a case series of 5 patients published in New England Journal of Medicine, just speaking to the dearth of literature on the topic early on, particularly in the pandemic. And then finally, this is a more robust analysis by a colleague of mine, Adam de Havenine, who's now up at Yale, again, published in Journal of Stroke and Cerebrovascular Disease, that was comparing mortality, which is something we were also interested in, comparing mortality after ischemic stroke in patients with COVID-19, and then comparing them to other patients with pneumonia or an influenza-like illness, or ischemic stroke patients that don't have pneumonia or an influenza-like illness. And what you see here in this graphic to the right is just, if you look at our control group, which are just ischemic stroke patients without a concomitant infection, this is sort of their rough mortality rate. And then you add in stroke patients with influenza, the mortality rate increases, pneumonia increases. Pneumonia, by the way, is very common in stroke patients, particularly severe stroke patients, because of aspiration pneumonia risk. So that's quite common. But then you look at this group with COVID-19 illness and stroke, and the mortality jumps up considerably, or the predicted probability of in-hospital death jumps up considerably. And this is a adjusted data set. This is from Vizient data, which is a national clinical database I'm sure most are familiar with. But this was sort of a prelude, again, all informing our interest in this topic. So that brings us back to our specific project. What were our hypotheses? We hypothesized that patients with both ischemic and hemorrhagic stroke and concurrent or recent SARS-CoV-2 infection would suffer a greater stroke severity. So not just an incidence of stroke, which is harder to look at in our observational data set, but specifically looking at stroke severity, and I'll speak in a minute about how we measured stroke severity, but that they would suffer a greater stroke severity compared to non-infective stroke patients. And we wanted to look at this again throughout the entire first year of the pandemic, from March till February of 2021. And not only that, but that these concomitant SARS-CoV-2 infected patients would also have increased exposure to mortality, and of the survivors would have longer hospitalizations than non-infected stroke patients. We queried the database, the N3C limited data set for adult patients hospitalized with stroke, using a range of ICD codes for both ischemic and hemorrhagic stroke that has been well published and sort of standardized as encompassing the stroke patients of interest that we wanted to look at. And we looked at the data from March 1st, 2020 to February 28th, 2021. I think we locked the outcomes in August of 2021 as far as mortality and length of stay and hospitalization as it relates to the data. And then importantly, I think for this analysis, and we can talk about this at the end, but we define a patient as having a concurrent stroke and SARS-CoV-2 infection or recent infection by any coded stroke diagnosis within 1 week before or up to 3 months after a positive PCR or antigen test. And now, at first blush, that might seem like a pretty wide range to put patients into our concurrent group, but at least for this first analysis, we wanted to be more inclusive, particularly with the hypothesis that there still may be a durable association of stroke risk after an initial SARS-CoV-2 infection. And so So then that's relevant to our sample set and something worth discussion perhaps. So I mentioned earlier about sort of how do we measure stroke severity? Well, there's a standard scale called an NIH stroke scale. This is well validated. It's used in clinical practice. It's used as a research tool. And it grades people on an 11-point or an 11-item inventory of neurologic deficits when they come in with a stroke. It has a range of 0 to 42, 0 being no stroke deficits, 42 being the most points you could score on this NIH stroke scale. So it's a large scale, but we see commonly that sort of the ceiling of this scale for most stroke patients is going to be in the range of 25 to 30, with milder stroke patients being anywhere from 0 to 5. Moderately affected folks are more 5 to 15 on the scale, and then severely affected folks are really going to be anybody with higher scales than 15 on the NIH stroke scale. And again, because we're talking about injury to the brain, some of this has to do with which part of the brain is affected by the stroke. But regardless, you can pretty much assign severity estimates or severity scores based on this stroke scale. And it's worth elaborating on just because it was our primary metric of interest as it relates to stroke severity. In addition to doing an overall analysis of our data set, we also narrowed it to a propensity score matched sample. And this was specifically in patients who had a coded NIH stroke scale on admission. Not every patient gets this coded, that we can actually find it in the data set, and this does vary from institution to institution. So when I show our flow diagram in a moment, you'll see that there was a fair bit of missingness of this metric, this NIH stroke scale, but nonetheless, we still were able to identify a robust data set or cohort, and then also specifically do a propensity matched analysis. And the propensity matched analysis, we did 1-to-3 matching, we did exact matching for race, ethnicity, and also N3C partner site. To the best of our ability, we wanted to try to account for any kind of variability in practice from site to site. We did nearest neighbor matching with a 0.25 caliper for other variables, and I'm happy to share the variables we looked at, but we used a fairly robust list of variables, and we'll see in our demographic of things that would also affect or confound one's stroke severity. The statistical analysis, we use several different metrics for our primary hypotheses. So as it relates to stroke severity, this NIH stroke scale, we actually used a Poisson regression analysis to calculate an incident rate ratio of differences in the NIH stroke scale scores. This is specifically because there was a rightward skew in our NIH stroke scale data. More scores on the sort of milder lower end than on the higher end, but that's the analysis we did specifically for the stroke severity stroke scale scores. For mortality, we did a straight up conditional logistic regression for difference in mortality, and then we looked at time from stroke hospitalization to death as well, using a Cox proportional hazard model. And then finally, length of stay, we did a generalized linear regression model. We log transformed length of stay. These are for the folks, obviously the survivors in the group, to look at differences in length of stay as our primary statistical analyses used. Again, this is a blurry slide. I apologize, but I just want to give people a sense again of what we're talking about with the NIH stroke scale. This is, again, the 11-point item. No need to memorize this tonight for our non-neurologists out there, but it does take inventory of a variety of different neurologic deficits. And again, talking about the different range and stroke severity that we see along the stroke scale score. So now we're going to get into what we found, our data, and this data has all been published in the Journal of Stroke and Cerebrovascular Disease this year, and happy to provide that reference in the manuscript for anybody who would like to see it. But this was table 1, our primary demographic table, and I want to just highlight a couple of points here. So it's a busy slide, but we see ischemic stroke over here in the left column and hemorrhagic stroke in the right column. You can see our numbers were fairly robust from the data set from this first year of the pandemic. So in our concurrent ischemic stroke group, we had just over 5,700 patients, and then we had controls of non-infected stroke patients, 37,530 patients in that group, and then lesser numbers in the hemorrhagic stroke group. Again, hemorrhagic stroke is less common than ischemic stroke, but still robust numbers overall. And these are the demographic data in this larger grouping that we had. So rough age, 69, 68, little less in the hemorrhagic stroke group, and this would be consistent with most other large stroke trials or stroke data sets that one might look at. a little less, little fewer women in the overall cohort than men. Again, similar to what you might see in an overall stroke cohort, more men in the hemorrhagic stroke group. And then we also saw some noticeable differences in race, ethnicity that I think are worth noting. Again, importantly, and I'll mention this at the end, this is not an epidemiologic study. Obviously, this group knows that. So we can't really generalize this to the demographics of the entire US population, but some noticeable disparities here when you look at patients with concurrent SARS-CoV-2 infection versus non-concurrent in our data set. So of our Black or African-American patients, there were more in the concurrent group, as well as Hispanic or Latino in our ischemic stroke cohort. And we also see disparity as it relates to hemorrhagic stroke patients, primarily in our Hispanic or Latino cohort, almost 10% more in the concurrent group than the non-concurrent group. So some notable race ethnic disparities here. This is important because we not only saw and have seen disparities in stroke and as it relates to COVID-19, but we've also noted this in our systems of care about patients reporting and being evaluated in an emergency fashion. So anyways, worth noting. And then I want to highlight a couple of additional comorbidities. So there was a difference in the proportion of diabetes in our concurrent patients versus non-concurrent patients, 55% in the concurrent versus 44% in the non-concurrent. And we saw something similar in the hemorrhagic stroke patients. So our infected patients were more diabetic. We actually saw fewer patients in the affected group with COPD. Interestingly enough, hard to know what to make of that, but given that we're talking about a respiratory illness, worth noting. And then we saw more patients with end-stage renal disease in our concurrently infected patients than our non-concurrently infected patients. And then getting down here to our metrics, our outcomes of interest. Again, this is in the unmatched sample, but you can already see sort of a fairly sizable difference in the overall stroke severity between the infected patients versus the non-infected stroke patients. So the total NIH stroke scale score here in the concurrent group was 9 compared to 5 in the non-concurrent group, and then was 15 in the hemorrhagic stroke concurrently infected patients versus 10 in the non-concurrently. And it's not unusual that the hemorrhagic stroke patients would have higher stroke severity. They're more severely affected because of the hemorrhagic bleeding on the brain compared to our ischemic stroke patients, but clearly notable differences in sort of the unmatched analysis. Also saw notable differences in length of stay. So greater length of stay, 10 days in the infected patients versus 6 in the non-infected in the ischemic stroke group, and 14 days on average in the concurrently infected patients with hemorrhage versus 9 days on average in the other. And then notable differences in mortality, 26% mortality in the infected patients versus 15% in the non-infected. And this 15% number would fall in line with your sort of general population with ischemic stroke, by the way. And then you see mortality increase in hemorrhagic stroke patients. Again, notable differences in the infected patients versus the non-infected patients. So almost a third or more of the infected hemorrhagic stroke patients unfortunately died of our data set. So that's the overall demographic. Digging into that data, this is how the samples flowed as it relates to our matched analysis. So again, overall ischemic stroke, acute ischemic stroke hospitalizations in our time period versus hemorrhagic stroke hospitalizations in our time period. These are the data we just looked at in our overall in our infected versus non-infected patients. And then we looked at specifically the NIH stroke scale total scores, and our data become limited. I mentioned earlier there was quite a bit of missingness in the patients who had total NIH stroke scale scores documented. And one thing worth noting when we look at our limitations, and there were actually differences in the rates of missingness between the infected patients versus the non-infected patients. Oddly enough, in the ischemic stroke group, there was less NIH stroke scale score documentation in the infected patients, but in the hemorrhagic stroke group, there was actually more documentation of the score in the infected patients than the non-infected patients. Not sure why that is, but it is potentially a limitation. And then finally, when we did our propensity score matching, where we matched in a 1-to-3 ratio, our algorithm kicked out a few of the cases that didn't have an appropriate match on the other side, but we get down to these smaller numbers for our matched analysis, but trying to mirror best we can a controlled trial of these different patient groups. So getting in again to our additional results. So this was a This is a histogram that I think is notable. It was not one of our primary hypotheses, but we actually looked at a temporal analysis of when patients who tested positive for SARS-CoV-2, when they suffered their stroke, basically. And so time zero here is that you are hospitalized with your stroke and you test positive for SARS-CoV-2 on the same day, day zero. And no wonder this is the biggest peak we have, because during this time and ongoing now, every patient that gets hospitalized is getting tested for SARS-CoV-2. So this is likely an artifact of being admitted for your stroke and getting a SARS-CoV-2 test, unable to say whether the infection has anything to do with their stroke or not. To the left of this peak, we see people that suffered a stroke and then tested positive some days later. This could be people that had an early infection that weren't testing positive early. But I think the most notable thing here is this trailing time period of almost a month or more, where you see people that test positive for SARS-CoV-2 and then have a stroke and are hospitalized with a stroke. And so this would be a more plausible patient population of people that they're testing positive and then they're going on to have a stroke. It's not an artifact of testing that's occurring here. And even though, again, we're not looking at incidence or prevalence in a fixed data set, but it is an interesting finding nonetheless. So getting to our propensity matched sample, these are the box plots for NIH stroke scale score severity, looking at every 2-month epoch over the first year. So this is March to April 2020. Sorry, you can't read this too well. And it goes down every 2 months all the way to January, February 21. And you can see here that the red box plots are our concurrently infected patients versus the green box plots, which are just our stroke patients without infection. And every single 2-month epoch, you see higher stroke severity in the concurrently infected group versus the non-infected group. And that goes all the way through the first year of the pandemic. So that supports our hypothesis that this was a durable effect and not just an artifact of the early pandemic phase. We see something similar in the hemorrhagic stroke patients. Again, sort of a blurry graphic, I apologize, but we see higher stroke severity in all the 2-month epochs, not quite as different as it was in the ischemic stroke patients. And notably, in the first 2 months, we actually didn't see that difference, or at least the higher stroke severity in the infected patients. And that may be, again, that may actually be part of the artifact that there's a difference in the way patients are being triaged to our academic medical centers and medical centers contributing to the N3C data sets because of concerns about infection and EMS and capacity and so forth in those first couple of months of the pandemic, when we were all trying to get our feet under us from a resource allocation standpoint. And finally, this is table 2 from our manuscript, and these are really our primary results from the propensity matched analysis. So again, looking at our main outcomes of interest, we have our NIH stroke scale score severity metric, and then the ischemic stroke group, we see a significant association with elevated stroke severity in the ischemic stroke patients. We see also a significant association with stroke severity in the hemorrhagic stroke patients, not as robust, but still significant. When it comes to mortality, the odds of mortality was doubled if you were infected with SARS-CoV-2 concurrently or recently in our ischemic stroke patients and our hemorrhagic stroke patients. So a notable association with mortality. And then also time to death, our hazards model for time to death, almost a 50% advancement in time to death in the patients with ischemic stroke concurrently infected, and a third more in the hemorrhagic group. And then we look at length of stay, higher length of stay in the infected patients versus the non-infected patients in both groups. So supporting our hypotheses that these patients are being affected in some way with the association with SARS-CoV-2 infection. So just sort of summarizing these results, in both our unmatched and our matched cohorts, patients with both ischemic and hemorrhagic stroke with concurrent or recent SARS-CoV-2 infection had greater stroke severity, higher rates of mortality, longer length of stay than our non-infected stroke patients. And again, this equated to a 2 times double odds of death, 50% increase in length of stay in the ischemic stroke group, and a quarter increased length of stay in the hemorrhagic stroke group among the survivors. And this was persistent throughout the entire first year of the pandemic. So moving now, just want to highlight a couple of the notable limitations. And I think as people are listening to this, they're probably thinking of a number of these on their own. But importantly, I think first and foremost, this is an observational data set, observational study. So we really aren't able to generalize these results to the full population to be able to comment on some of the relationships, particularly the temporal relationships I noted earlier. Importantly, and I think this is a major limitation for our data, at least, we did not fully control for the severity of COVID-19 illness in these patients. So we know that we can associate being infected with SARS-CoV-2 with an antigen or PCR test in our concurrent group, but we don't know how sick these people were. And it stands to reason that if one hospitalized stroke patient is severely ill, has COVID pneumonia, is intubated in the ICU, encephalopathic from hospital-acquired delirium, then their testing of their neurologic deficits as it relates to stroke are going to be confounded by the severity of their illness. And so we'll talk about future steps in a moment, but certainly that would be something we're interested in doing, is trying to control for some of these measures of severity of COVID-19 illness between these groups. Importantly, as I mentioned earlier, stroke patients are very prone to pneumonia. They're very prone to needing intubation, particularly the most severely affected patients. And so we could try to look at that as it relates to non-infected to infected patients with COVID-19. And then, unfortunately, we had a high degree of missingness in our data set, particularly of this NIH stroke scale score, which is our best measure of stroke severity between the concurrent, and these rates differed between the concurrent and non-concurrent groups. Our generalizability at this point is limited to the first year of the pandemic, but as I'll mention in a moment, certainly the data is there for us to look past the first year of the pandemic. And then while centers may differ in reporting practices, we did do some exact matching on enrollment sites, so hopefully accounted for some of those site-to-site differences. So what does this all mean? Again, sort of summarizing our primary results. No need to overstate it, but again, this large multi-center data set, one of the largest data set analyses of stroke patients with SARS-CoV-2 infection up to the point of our publication, we found that stroke severity, mortality, length of stay were all greater in the hospitalized stroke patients that either had concurrent or recent SARS-CoV-2 infection in that time frame that we allowed for these patients to fall into that category. And again, while not an epidemiological study, I do think the temporal analysis is really interesting, that trailing sort of 30 to 40 days after SARS-CoV-2 infection tests positive, that patients are still having an increased risk of stroke, both ischemic and hemorrhagic stroke, I think is suggestive. And I think more than anything, probably highlights the possible association, real biologic causality between stroke and SARS-CoV-2 infection. However, we need additional research to better understand these causation variables and also the durability of these associations out past that first year. And then while we noted some racial disparities in our data, again, not an epidemiologic study, we really can't reflect the US population, but no doubt there are true racial disparities as it relates to stroke, both stroke and COVID-19, and further research is needed to explore these differences in stroke incidence, severity, and outcomes between different groups. So at a broader level, I think these data contribute to our understanding of not only stroke and cerebrovascular disease, but neurologic complications overall and outcomes from SARS-CoV-2 infection. And that's really the raison d'etre of our neurodomain. And so we're glad to be able to sort of have this analysis out there as we're sort of just at the tip of the iceberg for understanding neurologic associations in SARS-CoV-2 or COVID-19. And then I think similarly, going back to my field of study, my field of interest in stroke, as I presented earlier, there have been a number of good lines of research leading up to this pandemic, suggesting that there's an actual association between people's risk of stroke from a variety of different mechanisms and having a systemic illness, whether it be an influenza-like illness or another type of viral or bacterial infection. And I think the more that we can really look at this robust amount of data we have at our disposal related to COVID-19 and SARS-CoV-2 infection, the more that we can also extrapolate that to stroke and infection and inflammatory states in the future, as we continue to hopefully put this pandemic in our rearview mirror at some point. Future steps as it relates to our specific area of interest in this data set. As I mentioned earlier, we really like to look at the durability of these associations beyond the first year of the pandemic. Of course, as this group probably already knows and is encountering, this brings in other issues related to the effects of vaccination, the impact of other variants of the virus, et cetera, and whether or not that plays a role in these notable associations. Importantly, I think we'd love to look specifically at stroke treatment and prevention. So Stroke patients, we try to get them in for acute reperfusion therapy and ischemic stroke and other treatments for hemorrhagic stroke. And as it relates to prevention, having them on different types of antithrombotic therapy. And I think that data is there in the N3C data set for us to be able to look at some of those associations in infected patients. And then finally, looking at longer term neurologic cerebrovascular outcomes. Clearly, there's a great deal of interest in long COVID and specifically long COVID neurologic symptoms and deficits. And this is just one other way in which we can consider this as it relates to cerebrovascular disease and our other analyses in the neurodomain. So with that, I just want to finish with, I'm sure many of you have read this great book, The Great Influenza by John Barry, which predated this pandemic. But specifically, I think this is a quote from the book talking about the influenza virus itself from this pandemic back in 2018. The virus certainly affects blood vessels, but does that mean, and what does that mean in terms of stroke, other cardiovascular problems years from now? And in 1918, there were complications that didn't surface until years later. And I think we're still trying to understand the impact of that today. And another credit to this group and this robust resource we have so we can continue to explore these associations in years to come. Finally, I'd like to dedicate this talk, as I do any talk related to COVID-19, to a colleague, Ivan Hassel. Ivan was a technician in our neurovascular intervention suite for many years, and he was one of our earliest colleagues to suffer and die from COVID-19. And with that, I couldn't thank enough N3C, the NCATS, and all the other sponsors who help support this analysis. I've acknowledged them here with a specific grant support, but specifically as it relates to UVA, my colleagues, Jackson Narrett, who was the first author on our manuscript. Jackson's now a neurology resident at Yale. Our colleagues Indika Malaraki and Chad Aldridge, Ethan Asefa, Arti Patel, all who helped with the data analysis. Johanna Lumba, who's one of our leaders, and I think you all know Johanna at N3C as it relates to our data resources, and Sarah Ratcliffe, who's one of our senior investigators in public health sciences. My colleagues in stroke, Brad Worrell and Karen Johnston and Don Brown specifically, who are the co-PIs of our CTSA here at UVA, our Data Science Institute, and our CTSA, which is iThrive. And then two colleagues, co-authors, Ofer Sadan at Emory and Tesha Monteith at University of Miami. So thank you all for listening. Really glad to be part of the group and happy to answer any questions folks may have. So thank you.
Andrew, there's a couple of questions in the Q&A. I can share my screen and show it for the audience because Q&A is only visible to the panelists, so it can be recorded, but I can read them out. So first one is from Warren, and it says, you may not have enough data to answer this, but do you see that vaccinations impact the risk of stroke?
So thanks, Warren, for that question. We weren't able to look at that with this particular analysis. Again, we were focused early on in that first year of the pandemic, sort of before the vaccinations really were were there to make an impact. But I think as subsequent analyses, we'd like to look at these associations further out. There have been some publications to the effect of high rates of vaccination in certain areas and populations. Putting a dent in some of this risk of stroke. I think we're still limited in some of these samples and data sets. So I think there's still opportunity to look at that in N3C going forward. But great question.
And then there's a question from David, and it says, was there any pattern in the missingness?
There was, David, there was a pattern in the missingness overall. I think roughly, and there was high rates of missingness overall. We started out, if I go back to, I don't know if folks can still see my screen or not, but if I go back to our flow diagram here, you can see we really had a lot of attrition when it comes to our overall sample sizes, and then getting down to the patients who had available NIH short scale scores. And so roughly like 80 to 85% of our ischemic stroke patients in our concurrently infected group did not have NIH short scale scores documented. And then with lesser degree, but still 70% or so in our overall stroke control groups, and similar in the hemorrhagic stroke group. So those are the data, those are the numbers. So as far as whether there are any patterns of missingness, as far as why how this could confound or create some selection bias in the samples that we were able to curate. That I don't know. I can't say yet because we don't have as good a sense of the reasons behind a lack of documentation. Again, we did control for partner sites, so hopefully accounted for some of that variability. But I will say, just for this group, it was when we started to do this, it actually was of interest to me that so many places did actually put a code in, an ICD code for an NIH short scale score, because up to recently, that really has not been done as a matter of course when it comes to documentation for stroke patients. And so it's not surprising to us in the stroke world that this would have low documentation, but it is certainly a pattern and potentially one that could affect some selection bias in our data set.
Yeah, I just one comment on that. I think Vizient now is scoring mortality, and one of the risk factors in the stroke models is the stroke score. So I think for academic and medical centers, that's becoming an important thing to document.
Thank you. And I think was there one in the chat?
Yeah, I think Ken had a question in the chat.
Now, let's see. Were we able to differentiate between subcortical versus cortical strokes? We did not specifically differentiate that in this data set. It's a good question because ICD-10 coding for stroke is highly heterogeneous, and you can get very specific with your coding. So I could code a subcortical ischemic stroke. There's a specific code, subcode, I think, for that. And again, if folks are experts on these various codes, please feel free to speak up. But you can also then provide a subcode for a patient with a left middle cerebral artery cortical ischemic stroke. And so it can be very specific. However, much of the time, and I suspect much of the time in our data set, people give these more generalized, ischemic stroke or cerebrovascular accident or pre-cerebral artery stroke. And so unfortunately, at least our thought was there was just too much heterogeneity. And if we got too specific on trying to find specific stroke subtypes in the coding, then we would probably dilute our sample sizes a fair bit. But that is something that we could explore as a sensitivity analysis.
Andrew, thank you. I guess what's really interesting me is, we saw a lot of strategic infarcts for folks who had diabetes or other vascular diseases and white matter disease. And I was just curious, but I totally understand it's such a difficult area because it's, like you said, it's so variable. It's tough.
No, Ken, I mean, I think from a scientific interest standpoint and a biologic, plausibility association standpoint, I think you're spot on. I mean, these are the questions we really would like to know. Is there an association between the virus and certain, arterial beds, subtypes, disease states, or cerebrovascular disease states? We've seen reports for all sorts, but I think really trying to narrow in on that would be of great scientific interest.
We are, it's an experiment, so I don't want to overstate it, but we do have MIDRIC images in N3C now. They're not available for everybody because we're still testing them. Most of them are CTs of the chest and chest X-rays, but it might be worth it if you're interested to explore what MIDRIC has. I'm sorry, MIDRIC is the imaging N3C of NIVIB. Sorry, I should have said that at the beginning. And we're trying to link these two enclaves. So one thing that might be possible, maybe, big maybe, is to see if we have some CTs, head CTs in that, or potentially could get those and link them to, and then we're linking them to the patient. So, but anyway, thank you. Nice job.
No, I appreciate that. That would be of, I think that would fall right in line with our interest. And I didn't know that imaging data was available. So I would love to explore that. So thank you, Kim. We may follow up on that.
Okay.
There's some additional comments in the Q&A. I think from Clement. Does the data regarding stroke incidence mirror that of COVID-19 as far as the cities most affected?
Well, again, I hesitate to say much about incidence as an epidemiologic measure just in the data set, because we really were looking at the observational data and then obviously looking at a very specific propensity match sample. However, I do think what we've seen in the stroke literature does suggest that the disparities mirror what we see in COVID-19 in general, and that there's higher risk, potentially even greater mortality and severity in Black and African American patients, Hispanic, Latino patients compared to other groups. And again, I think that's something that would be worth exploring as a follow-up analysis, but unable to really say much about that as it relates to a general population epidemiologic analysis at this point. I will add that just I didn't talk as much about sort of the effect of the early pandemic on systems of care, but there were also significant racial ethnic disparities in, for instance, patients accessing the emergency department early on in the pandemic for stroke, comparatively, and particularly patients from rural, socioeconomically disenfranchised regions. And so, again, these are things that we see in stroke medicine in general, that there's great disparities that we need to address and try to understand better. But we also saw that interaction with this pandemic as well.
Okay, I think there's a comment from Mary Emmett. Thanks very much. Your observation about infection and the association with stroke is certainly worth investigation. And Warren also mentioned that your figure 1 was tweeted by Dr. Topol, so Twitter fame, right?
Thank you, Dr. Topol.
Yeah, and then Warren also follows up with different N3C group is looking at cardiovascular events, COVID-19, and vaccination status. So I think Warren's also, I think, a member of that group. He said it seems like a good group to collaborate with. So,
well, thank you, Warren. I was aware that there was a group looking at vaccination status and potentially cardiovascular association. So certainly, stroke is a cerebrovascular cardiovascular association, and so we would love to collaborate. And I'll talk with Johanna and Don and Karen and my team, and we'll follow up. So thank you.
So I have a question myself. So are there any thoughts? I guess you're going to try to extend this to the next year, right? With changes in the, also one of the recent enhancements within the N3C is the inclusion of mortality data outside of the hospitalization. So any thought how that could be helpful in the analysis to note?
I do think that would be helpful. We see that in stroke patients in general, there's obviously in-hospital mortality in the most severe stroke syndromes and the ones with higher severity. And again, being that is something we found being greater in the concurrently infected patients, that's of interest. However, there is a durable effect of mortality on stroke patients in the first 30 days after their stroke, and it even goes out to the first 6 months in most data. And so I think out of hospital mortality would be of additional interest, and I hypothesize it would support what we found within hospital mortality. So thank you.
Okay, I think we've got all the questions answered. So thank you very much. This was a great talk, and it's great to see, initial things that were seen in the pandemic, right? And to see the detailed analysis that your group did, showing these strong effects. So, and I think we're all interested in seeing the follow-up work for this.
Well, thank you.
We'll, doctors. Yeah.
We will we'll keep at it. And again, I appreciate the audience, and I want to emphasize that I was just a small part of this, and Johanna Lumba and our analysis team and the other folks that run our CTSA really are so important to this work. So thank you all, and glad to be able to present and work with you tonight. So thank you.
Yeah.
Thank you, Dr. Sutherland.
All right. Take care, everyone. Have a good night. Thank you, Karen.